Again, really excited to keep this conversational and flowing. So we're a few minutes in. I'd like to get started. Welcome and good morning. I'm sure a few more people will start to roll in. If you are able to join us on camera, all the better. We'd love to interact here and keep this conversation going as organically as we possibly can. So hopefully some of you were able to watch that opening. I loved it. As somebody who started an organization and started companies, it was just right on target for where we want to go with solving these problems. And I've got some follow-up to keep us going from the chat. And if you didn't, I highly recommend you go back and watch it. I know it will be available. So this morning, the chat is going to be, how do we erase the stigma? How do we, there's clearly a stigma, and how do we erase this stigma around mental health and getting mental health for cancer survivors? And now we can talk in general about the stigma around mental health, right? Because it's not just limited to one specific task. But ultimately, what we want to do with this conversation is keep moving forward and get to solutions. Because the beautiful thing about this is we're here with Livestrong. We're at the Livestrong, we're at the Icon Summit. And in the end, these solutions and this conversation will actually lead to ideas and generate opportunities that can potentially get funding. That money can go towards these ideas, and any one of you or anybody else can kick off and make these a reality. So that said, we would really like to, can everybody hear, is the audio all right? I have a lot of you are on mute. Awesome, thank you, Katie. So that said, I don't plan to talk a lot. I can and I do that, but this is a conversation in a lot of brighter minds than mine for sure, and we're really excited to have you. I'd love to start the conversation with that. How do we solve for this stigma? What is there? What exists? And what are some great ideas? And I'd like to start with one of those options, getting us towards how do we reach for weird? What are the option X's? So we can really lightning forward to some solutions. Who would like to start us off here? I'll start us with, I started an organization that covers the cost of mental health for these families that are coping with cancer. And we do paddleboarding events, we do surf events, we get on the water, and we're trying to make it cool for a younger demographic to talk about getting help, make getting help something that's germane to their lives and get going. And it's just a very simple approach, but I'd love to, again, put it out there and start that conversation. Let's talk about the issue itself and how we can get to solutions. Is there anybody that would like to respond to the challenge that there isn't stigma around this? Maybe I can start it there. If I was to tell you there is no stigma around getting help, depending on where you live and what you're doing, I'd like to challenge with that statement.
I'll actually jump in here. Pamela Crouch, Executive Director of Living Proof Exhibit, and we provide the therapeutic benefits of the arts to people touched by cancer. And what we have noticed is people are, when their hands are busy, they're willing to talk about how they're feeling emotionally, but they're not willing necessarily to sit around and talk about how they're feeling just in a group setting. So we have different conversations. I'm a cancer survivor myself. Every cancer survivor approaches mental health in a different way, and I think it's important for them to be able to have options as to how they're going to reach, so that they have options to reach out to different people. A wellness group might work for someone. Creating art might work for someone else. So being able to have those options are really important for people.
I'd agree. And if we take a step back, the options, assuming that they are ready to accept and get beyond the stigma, right? are there any of you that feel like that this, I mean, you've joined this conversation, that there is not a strong stigma around it? I believe that people do. I've done this for over a decade with our organization, and people try to challenge me with that.
I guess I have a couple questions about what we mean by stigma, because I guess A,
Excellent.
do we think that the stigma here is different than the broader stigma around mental health and getting help for mental health, which I think exists at large?
Yep.
But then also, I'm also a cancer survivor. And so I think there are different, are we talking about stigma from other people, or talking about the stigma we put on ourselves? And we might not even recognize that we need help or want to recognize or admit that that's a problem. So the stigma can be at different levels and can come from different sources. And so I don't know if we want to try to target it that way, or if we're just talking about it at large.
No, I think that's fantastic. I think that's a very good point to break down the problem at hand, or as we see it. How do you see it? How do you see them different?
Well, I think if it's coming from ourselves, the person has to recognize, the survivor has to recognize if they need help and be willing to ask for that, or get over the self-imposed stigma before they'll even make an effort, I think. That said, some of the self-imposed stigma might come from what they think they're perceiving from external folks. So I don't know. I'm just raising the questions because I don't have the answers.
Right.
I will say, having gone through it myself, it took a while to realize that I'm still struggling with things emotionally and mentally, because it's such, it's pragmatic at first. You have this big checklist and you have to get through it. There's surgery and there's radiation and there's this and there's that and there's a doctor's appointment. And as long as there was a checklist, I was fine. And when you start to get closer to the perceived end of the checklist, or the things aren't coming as fast and furious, then the emotions start to set in. It was weird. That was different. And I didn't know what that was. And my doctors never said, hey, by the way, at some point, you might realize that this is a really big emotional journey for you. And so maybe it's something that even the medical professionals could lean into, but because they didn't say it, I didn't really recognize it right away. Sorry, Scott raised his hand.
Oh, excellent. Scott?
I think it's, an interesting question, and I want to maybe discuss real quickly my case. I am a survivor, and I had a brother-in-law as a survivor. My approach was, I felt I was going to get through this if I had a community with me. And my daughter, who was most supportive, set up a caring bridge, and I had like about 50 friends. And she posted updates every time I had a treatment. And they were like cheering me on. And that's what I needed for my mental health. Whereas the brother-in-law, who didn't even tell his siblings, I was the only one outside of his wife that he told. And I think he struggled more being alone. Because, treatments, it's tough. And depending on your case, it has its ups and downs. And in my case, I found my mental health was strong because I was able to keep a positive attitude because I had the support of this community.
Can I make a comment?
Leslie, please.
Yes, I'm a psychologist, and I've been working in one of the most stigmatized areas of cancer care for the past 40 years because my specialty is sexuality and fertility related to cancer. And, one of the participants mentioned the importance of having the oncology team proactively bring up the topic. And we know that for any aspect of mental health, that's really important. The estimate for sex and cancer is that maybe 10% of people with problems are desperate or assertive enough to bring it up themselves. And it's just such a battle getting anyone on the oncology team just to ask one question so that they can get the person into resources and assessment. And the other issue with all mental health and cancer is the lack of resources. There's a lack of trained professionals. There's a stunning lack of money. And one of the things I've noticed over the years is that women with cancer, maybe a quarter at least of women, end up on drugs to reduce anxiety or depression that, when it probably could have been better handled, or at least as well handled, with some brief counseling, and then no one ever takes them off of the drugs. So 5 years later, they're still taking anti-anxiety medication. So it's very frustrating.
I'm sorry, unless you want to respond to that.
No, David, please. I just want to keep this conversation going. Thank you, please.
Sure. I'm a designer, product experience designer, and this is a complicated behavior change issue. And when we look at behavior change, we try to take it apart because it's so complex. And when we talk about a stigma, that's a belief. It's a belief that one has about a certain reality, and those are highly influenced by all the stories that you've been told over your life, stories and sort of dogma that you've been told. And the world we live with, anytime we're less than perfect and less than achieving and less than awesome, we have a stigma of like, didn't quite get there. And athletes have worked that through, like, well, it takes a lot of work to get there, and there are these plateaus and things. We all have stigma around even getting a cold, like someone sneezes and everybody's like, so we all have this. And mental illness is huge because a lot of people we don't understand it. We think it's all made up stuff, so the world has loaded people with cancer and a mental illness doubly, right? So the way you change a belief is with stories. It's with stories of other people like you, because what you live with is like, oh, I should be able to get out of this. Like, nobody has this problem. Like, this is just cancer I'm dealing with. Why, and so other people's stories help you understand that, like, no, like, other people like me go through this, and they change. Things change afterwards. Like, you can go from here to there. And so that's why all these stories, professional testimonial, celebrity testimonials are so powerful. It's like, oh, even someone that powerful, that talented, that rich, that famous, that good looking can have this issue. And then there's a solution for them. Like, maybe that can work for me. So I think as around the stigma, it's stories. Stories can change the way people view and change their beliefs around actually activating. So then there's also the mental model of like, what the heck is a mental illness? Like, does this mean I'm crazy? Well, schizophrenia is different than depression, and they're both different. They both work in different ways, and there are treatments for both things, and they work in different ways. Like, oh, that's how that works. Like, now I understand. Like, there's a chemical change, or there's a whatever. Like, so mental model of what's going on there is pretty important to grok. Otherwise, like, what do I don't know, do I just have to talk about it? No, well, some of this is chemical, some of this is talk, some of this is both. And then, like, how do you make that happen? Then there are these acts that you have to build in. Men and boys like to do activities, and then they'll talk about their problems. Sometimes women are more open just when they trust someone and they're drinking tea, like something that feels warm. So I think if we break it down, there's no one thing, one change of this experience that will solve the stigma problem. We have to understand the different aspects and figure out how to blend these different interventions into an experience that in the end gets people in, gets people comfortable, and then gets people engaged.
Excellent. That's right on for the group. Just so we're all kind of rowing the same boat here. Thank you so much for that. And I love that you're a designer. We can get more into that when as the solutions aspect, but different ways to actually manifest what we're talking about. But posing first now for these next few minutes, would love to finish up hearing from you guys sort of what you think this stigma means that we're talking about. What is it, defining it, talking about barriers, any of your own experiences, because the next sort of half hour, we really want to go hard at solving for this as we sit and define, this is going to be very solutions focused, right? And that's our goal. I think this is a powerful group. We can come to that and get to real steps and a novel approach to solving for this. I'd love to hear from a few more of you first, before we get to this heavy solutions discussion on sort of what this conversation means to you, your definition of stigma that we're talking about, or what sort of barriers.
I'd love to chime in on the stigma. I just finished treatment for cancer a few weeks ago, and one of the things that I saw many different doctors, oncologists, surgeons, and they started telling me, make sure you're seeing a therapist. This is heavy stuff, and if you're having trouble processing it, by all means, work through it and handle it, because this is emotional as well as physical. And so I almost, in my family would ask, my friends would ask, how are you doing? Are you able to get some mental help on this? Because this is a lot. And I almost feel like there's kind of a pass given. If you're kind of actively going through cancer, people kind of know you're going through it. And if you need additional mental help, great, go get it. And I'm kind of curious to see for myself, now that I'm done with treatment, now I'm kind of unpacking all of the emotional and mental everything I went through. And I'm kind of curious to see, like, am I going to still see that attitude where people say, go get therapy, get the help you need, or is it kind of, you're done with cancer, so I guess all the mental stuff is done too. So I think that's something interesting that I've noticed, at least just going through treatment over the last 6 months.
Yeah, that's great input. Would anybody like to respond with that, with their experience or their understanding? I think it's something, Elizabeth, thank you for sharing that. It's something like for us with Flatwater Foundation and, the past decade and the work that we're doing, we have to look at this not as insurance companies see 6 sessions and you're done. 2 months, like we're talking about, this comes back. So, we've got to look at the long-term and the years and the different ways it comes back.
Yeah, absolutely.
Yeah, absolutely. And so we're talking about a solution there, but the actual stigma that can be created, right, by being done, cancer-free, like what the words that are thrown at you. Any other experiences that we'd like to share before we really start going hard into solution focused conversation, or your own experience with barriers? What creates, I think, Heather, it was you that said self-imposed. I think that's a great point we can pick up on, right? Self-imposed versus community versus your doctor, the hospital, your peers. Where does this come from? Are we our own creators of stigma? Where does this, so we can start with a solution, what's creating the problem?
I think one issue, particularly for men, is that our culture is so relentless in telling men what it means to be a real man. And cancer treatment often takes away some of the most important parts of that role. A man is supposed to be a caregiver and is supposed to support a family financially, supposed to be sexually competent, supposed to not show any weak emotions. And that makes it especially difficult for men going through any kind of chronic illness. And then I think women have some of their own issues, women also being told culturally that we should take care of everybody else, but, not need care for ourselves. And so I think there are, some gender issues there that add to the stigma.
I think also for people of faith, I feel like they feel like there's an expectation that they're supposed to be okay and hopeful and positive. And so I get the feeling like my sister just got diagnosed. And yet every time I talk to her, I feel like she feels this pressure to say she's confident, everything's going to work out. And she's on this high road. And I just keep wondering, like, at what point are you going to actually allow yourself to feel what you feel about this? So I think there's this expectation for people of faith to stay on a high level with it.
That's interesting. I hadn't thought about this before. And for me, it wasn't about faith, but for one of my first thoughts when I was diagnosed was, how the hell am I going to tell my family? And so then I felt this need to kind of downplay it and to be really positive for my family. especially like my mom, who I knew would just flip out. And so there was almost that, okay, I have this, but I now need to take care of my family and make sure they're okay with it. And I don't know if that stopped me recognizing my own emotions, but it was definitely, I didn't even think about it, Sharon, until you just said that.
Yeah. And we talk about gender, we talk about faith, we talk about each of these points, culture. You know, I'm a Hispanic male. There's, you know, there's a long history, there's a seated culture, beliefs and values. I believe we need to take all those into consideration when we start talking about a solution, because there's not one arrow, right? There's not a bullseye we're aiming for here. Is there anybody else can share sort of an experience that would like to, before we move on to really brass tacks and thinking about how we can solve this? Raise your hand if you were able to see the opening video today, because I might reference it a bit, but if not a lot of us, oh, excellent, okay. Because as we move forward, I want to talk a little bit about reaching for the weird and the option X and a lot of what he just talked about, because I mean, it's what we have to do, and it's kind of the way I approach things. But I'd love to keep it in that vein to continue his conversation. Is there anybody else that would like to share on the problem?
Can I just toss out one more potential
Please,
question?
please.
And I don't know if this is, sorry.
No, good.
I don't know if this is part of it. The original question, as it was in the agenda,
Yes.
was something about erasing the stigma of mental health for cancer survivors and their families.
Yes.
And so one of the reasons, other than my own personal experience, that this resonated with me was we just lost my father-in-law recently, well, a couple of years ago now, to cancer. And I've watched my mother-in-law try to deal with that. And no one, so similar to the doctors not really suggesting help, like no one was offering her help or suggesting anything. And then it took a long time for her to be willing to look herself. And then it was really a struggle, because I think finding the right help for a very specific type of pain. And she really struggled to find someone who could at all relate or empathize, or it wasn't just a general, I lost my husband. You know, there's a lot of different kind of suffering that goes around with losing someone this way. And so even if you can get past the stigma to finally ask for help, not being able to find the right help right away set her back quite a while. She was like, well, see, the help's not out there. So, you know, and so I don't know how that plays into this or if it does, but that was something that's more recent in my mind. So I just wanted to throw that out there.
Actually, Heather, if you don't, thank you for bringing that up, because I'm a 4-time cancer survivor, and my husband couldn't fix it. So he struggled, and he still, you know, my last diagnosis was last year. And for him, he felt that more of a stigma. I mean, people were helping me, they were reaching out for me, but they kind of forget about the spouse or the partner. And I think that mental health struggle is really challenging. And so thank you for bringing that up, because that's a part of it that doesn't really get discussed. And I don't know, Leslie, if it goes back to having the oncologist sitting down, you know, people in talking to the patient and talking to the spouse / caregiver. But I think that is a real struggle. And that's actually what kind of brought me to this too. I think, you know, I can reach out and find support, but how do we support those who love us and those who've lost and yeah.
And in fact, caregiver stress is a huge issue among mental health professionals who take care of people with cancer and other chronic illnesses, and there are scales to measure it and ideas of how to help. So it's definitely not an ignored issue, but again, in a hospital or a cancer center, finding the resources and allocating them and paying for them to do what we know, you know, needs to be done is another issue.
Absolutely. Well, so these, at the core, as we discuss getting help, we run on the assumption I'm through the stigma and I'm past it and I'm going to go find it and seek it. So I do agree with you. It is a part of it and it does play in. What we'd like to do sort of as a community and as Livestrong and as this the summit is talk about how we can erase, and thank you so much for that too, the stigma of mental health for cancer survivors and their families. And that's major for all of those reasons. It's huge. And I would even argue that potentially on the caregiver side, there's a little bit stronger battle, because there's also, like for me, losing my dad, there was like, I don't have cancer. I'm not going through the diagnosis. Like, what, I don't want any of this attention. I don't want to think like I'm going to get the help. It needs to go to him, whatever. We struggle with it in a different way, but I think it's an important part of the solution. With that said, are we all comfortable sort of moving the conversation now very heavily into a solve? Let's look at ideas on how we solve this, pushing towards real steps. This is being recorded. This is a brain trust here. And the goal, like I said, at the end of this conversation is to look at ways that we can come out and potentially even fund through this organization and this group, make these ideas real. David, I love the idea you're a designer and you work on products, and there's that aspect. I don't know if it's digital or where you're at. There's that aspect of it. And then if we think about what he was saying in the opening, right? The bananas, the ripened bananas in order. This doesn't take PhDs and rocket science to think about these. Let's start there with some simple approaches to beginning to craft a solution. What is important? What are the important ingredients of a solution to ending stigma? Can I pose that?
Yeah, sure. I'm Stacy. I'm a licensed marriage and family therapist. And
Awesome.
so I'm thinking a lot about normalizing for the patients and families, and then also accessibility. So those two things of like really putting out a solution that can help those patients and their families just have to be normalized that it is okay, that obviously this is a hard road and a journey and you need help navigating it. And then the other piece I think would be accessibility, of just kind of putting it out there that people know where to go. I'm thinking even like community-based, our world's going more to online, some type of, just something community. So I think two of the things for me is the normalization of the care, the mental health care, and then also the accessibility piece.
Awesome. I mean, yeah, you can tell somebody there's no, like, get rid of the stigma, drop the stigma, lose the stigma, go, 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 and then they hit a wall. There's nowhere to go. Okay. Excellent. Can anybody build on that? Heather, did I see a thought?
No, I was just agreeing. Yeah, so if we get to the point, so that was kind of my mother-in-law's story, right? If we work through, you have to work through a lot. Some people have to work through quite a bit to even get to the point that they're willing to ask for help. And then you go through that fight, you get to the point that you ask for help and you can't find it. And it just kind of shuts you down and you're back to square one. So I agree that we can't, solving one without the other doesn't actually solve the problem.
Absolutely. Now, are there, coming into this conversation, have any of you had sort of preconceived notions of what is missing or ways that we could potentially start to solve this, eliminate this? Is there anything that you've done or worked on to do that?
Well, I can tell you a little bit about what I've done over the past 5 years. I was on the faculty at MD Anderson for a long time and had grants and funding, and I developed online self-help tools for men and women for sex and fertility and cancer, and turned it into a company. And I've been struggling with it for the past 5 years, and I'm probably about to close it. And it included stories and normalizing and all the things you're talking about. But it can be, just trying to get somebody to pay for this stuff. It's so expensive to develop and to maintain. And so, it all sounds great, but when you actually try to do it, it isn't, I feel terrible because it makes me heartsick for 20 years of work to go down the drain. But, I've tried everything I know and consulted all the experts, and it just, maybe we were before our time, but it hasn't worked. But I think it's great to try to come up with these solutions. And it certainly started for me when I saw the internet back in 2000 as starting to be a source of health education and knowledge and support for people. One of the issues I think we need to try to work with, and I'm a cancer survivor as well as a professional, but I think the influence of social media and peer support, and where do you put in the professional support component, is a real issue, because I've seen a lot of online groups giving misinformation and misguided attempts to help. And on the other hand, I know that when they work well, they can be great. Now, I'm not sure how to shape those things so that they're always a force for good.
That's incredible. Thank you for the work that you've done. The last question I'd posed about barriers, experience and barriers, a major barrier here is money. Major. I mean, that's going to be any sort of solution and funding. The goal here is take those learnings, isolate them, and then solve for all the pieces to get there. And that's going to be a huge one. I couldn't agree more on my last decade of work.
Mark, if I can just comment, this is Srini. I'm the founder of a digital health company in San Francisco focused on cancer care, and I feel for Leslie, and I'm really hoping that the idea was just came well before its time, because we know that this is a much needed, very much misunderstood, part of the equation of all those healing modalities for care. Towards solutions, a couple of things I maybe will mention, and this is right out of that, MacGyvering or, kind of thinking out of the box type of a thing. But, one aspect of all of this, and, I really don't have a dog in the cancer fight apart from starting this company, is I didn't really understand how big mental health was part of all of this. And one of the reasons I joined this was to really understand more. But I feel like, given that it's maybe not part of the mainstream part of care, maybe becoming more aligned with the core healthcare team may help, help the cause in terms of bringing mental health into the mainstream. And I think Leslie kind of alluded to that, about 10 or 15 minutes ago. The other part to this is, and we've been talking about stigma, is also around this idea of calling it mental health. I mean, being a guy, I also have that stigma. So, I'm kind of reminded of Kentucky Fried Chicken, right? So, how they rebranded themselves as KFC to get people to stop thinking of them as fried chicken. So maybe there's an opportunity to kind of just potentially kind of rebrand this field into something else. I don't have a great suggestion, cerebral health, but I don't know, I don't know what it is, but there's potentially some scope there. But I think bringing this field closer to the core healthcare team, whether it's a nurse practitioner or a social worker within a hospital setting, and really piggybacking off them to offer these kinds of services to new patients and caregivers may be a way that we're exploring, right? We're an early stage company, but I just wanted to kind of provide that comment. Thank you.
Excellent. Yeah, Scott.
I think you raised a good point, and maybe Leslie can address this further, but I was treated like many people were at MD Anderson. And my first appointment there was introduced to my doctors, which happened to be a surgeon and an oncologist. But the social worker that they tell you later is available for you should have been part of that initial meeting. And I think that might be a possible way to approach this. Typically, the mental health people are in the background, and they don't later tell you it's available, but they're not up front as part of your healthcare team.
Yeah, I'd like, if I could just piggyback on top of that. So mental health care has a bad rap globally, right? For the last 1,000 years. I don't know. So that's a huge issue. I think the opportunity we have is, and people will avoid mental health care their entire lives when they could use it to be happier, more productive, whatever. We have their attention with cancer. Like, they are here. They're sitting in a doctor's office. They are listening to a serious change in the way their world is working. And cancer has a very clear it's got a clear image of, you got to fight this thing, right? That's how we deal with cancer, right? It's a fighting. It's a battle. So we've got their attention, and I think Srini's right. If we brand the mental health care as, okay, so we've got oncologists, we've got infusionists, we've got like boom, 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 boom. We've got chemotherapists. Like, we've got a team who are focused with you on fighting this, and this person is there too. They're not like if you need it. They are critical. They are part of it. So this is mental model. Like, this is how it works. This is a critical piece of your care. It will go on. It will seem like it's not working, just like these drugs. You don't know, there will be side effects. It's the same. And so that's one way of that's an idea, is integrate it very clearly and very unambiguously as part of your care. Everybody uses it. We are going to make you an appointment. There's no option there. Done.
Yeah, I really like that, David, and I feel like we belong to this mutual admiration club now, right? The way I think of this is, like, oncology it's a team sport, right? Or it should be a team sport, but it's not practiced that way. Yeah, I mean, you can talk to nurse navigators and various people in the healthcare profession who go to these tumor boards, and it's the head oncologist who kind of drives this, the patient side of things forward. And I don't think that should be the model. I almost always am kind of reminded of the rowing, the crew sport, right? And there's 8 rowers in a boat with the cox guy. And the 8 rowers are in a healthcare cancer setting, right? So it's the oncologist, it's the genetic counselor, it's the mental health therapist, it's a social worker, it's the nutritionist, right? And maybe 2 or 3 other folks as well. So all those people should have the same level of say towards that patient solution or treatment. And unfortunately, it's very lopsided right now. And that's what we've got to fix. And that's what we're trying to fix with our platform, which is in its early stages. So anyway, just as an idea.
That's excellent.
I would just comment that, I couldn't agree more. However, having worked in hospitals for 40 or 45 years, nothing's going to change until insurers are forced to pay for these services, or we have a one-payer healthcare system that works on value-based care. And as much as we all would like it to be that way, what the hospital says is, my medical social workers have to work on placements of, who's going to go where after they leave the hospital. Very few of them have the leisure to do more than a few minutes of counseling with patients. And tell me a cancer center that has an excess of social workers or even advanced practitioners who are trained to provide some mental health services, much less the even more expensive psychologists and psychiatrists who provide services. It's very sad, but every hospital is stretched incredibly thin, and even in the community, the reimbursement for mental health care is so poor. And telehealth, there's a big fight about how long it will be reimbursed after the pandemic is over, and it's just a really huge problem. So I just want everyone to be aware of that.
I agree. I will however, go reflect back on the innovation talk we had this morning and say, like, any company, hospital or otherwise, has to reallocate funds and teams and things as things change. And so if there's a way to demonstrate beyond conjecture how this is such a critical part of the cancer journey, and it's not, this is an equal, should be considered equal to, almost equal to the oncologist, or, you know, as others were already saying. So if this is the team, like Scott, your point of, when I'm introduced to my team of doctors, that social worker should have been there from the start. It shouldn't be later, like, oh, by the way, there's this person if you need her. I was shocked, going back to my mother-in-law again, and my father-in-law, when he was in the hospital, and he was in a great hospital with a really well-renowned cancer center. And I kept suggesting to her, like, they must have, I can't imagine a renowned cancer ward that doesn't have emotional support or social support there. And there was just nobody for her to talk to. I was shocked and really, really disappointed. Like, that shouldn't happen. And I hear you, Leslie. It's going to be a huge uphill battle with budgets and all of that. But I don't know, like, I'm struggling to think, because I've been through it myself and I've just watched my family go through it. Having a cancer ward without any kind of emotional support is incomplete. And actually, if I can ask, Elizabeth, you mentioned earlier that your doctors did talk about it early on. I don't know if the support was available there on the team, or how did that play out?
You know, I had to do my research. I had to go out to some of my regular doctors and ask them for recommendations. As you said that, I was thinking through and thinking, yeah, that would have been really nice to have someone actually in the office. But no, I had to go out, do my own research. It was kind of on me to get that initial appointment and get it on the calendar. Whereas a lot of other of my appointments, you know, of course, when you first hear you have cancer, you're kind of in a fog. Everyone else kind of came to me and put stuff on the calendar and said, show up at this office at this time. Mental health, no. It was definitely on me to go out and find a provider and get it done, and kind of on myself. So as you said that, I'm thinking that's something that was missing is, you know, that kind of being considered part of my medical team, and someone who would have just kind of taken the reins and said, here's who we think would be a good fit for you. Here's a couple other options. Go forth and get help. So I completely agree with you on that.
Yeah, I think the other part to this, kind of just piggybacking on what Heather said, I mean, it sounded like, you know, you went to a renowned hospital in maybe kind of a large metropolitan type area. But, you know, there's a stark difference between the type of experience and the team that you get there versus, let's say, somebody who is in Lincoln, Nebraska, or 200 miles outside of Austin, Texas, right? Where it's really a small practice with maybe 2 or 3 oncologists. They might have a receptionist and that's it, right? So even this whole idea of a social worker and nurse navigators we're talking about, I mean, mental health is way down the road, right? They don't even have the bare minimum. So I think there's some potential areas there where, there's a stark difference between community and hospital settings, I guess is the main point.
Very true, and even more so between rural and urban settings. And that's the blessing of telehealth, that we can reach out further, and we need to break down the barriers with interstate licensure and reimbursement so that we can offer more services to more people.
Absolutely, Leslie. And so, sorry, Mark, go ahead.
No, please, Srini.
No, I was just going to say, and that's why, Leslie, I think I said earlier that I think you're right. You know, your idea for your business was maybe, well before its time, because especially now with COVID and kind of a paradigm shift in how health will be delivered, kind of the rise of, employers who are self-funding, right? So you don't have to go through the BUCAs of the world, right? The Blue Shield, Blue Cross, or the United, or the Cigna, or the Aetnas. There are other self-funded employers who are starting to look at this and saying, hang on, why are my premiums, anywhere from $30,000 to $50,000 per person for healthcare? That's just ridiculous. And they're starting to look at some innovative models. So, it's not something that's going to happen right away, but, I hope there's light at the end of the tunnel.
I'm curious, keep talking about mental health in a hospital setting. Locally, our organization receives referrals from the hospital team. And I remember when I was first diagnosed, I was given all the information about Gilda's Club. So what partnerships are, and Gilda's Club, of course, has the social workers and the wellness care, and their programs are all free. Our programs are all free. What partnerships are out there? What collaborations are out there that are available? So doctors who are worried about just keeping us alive, the nurses, the nurse practitioners, etc., would be able to refer people to organizations that specifically deal with mental health and recovery, what happens after you stop seeing the doctor and stop your treatments, Elizabeth, that kind of thing. Rather than staying within the hospital system, what partnerships and collaborations can we think of? Because that's what's going on here in our community, is that we have partnerships with the hospitals. They send the people to us, and we take it from there.
Yeah, I think that that's an excellent point as well. It's gonna go. So we're about the 10-minute mark right now, just for everybody's awareness, and we're gonna start pushing real hard towards actual steps, novel approaches, what we can do. And these are all incredible thoughts, because we're talking about therapy and getting the help down the line of the stigma, at the point that you're looking for help. And we've gotten over that sort of aspect, which is excellent. I think that's where we all need to get. Let's talk about what we can do with a quick summary. That goes back to, I believe it was Stacy, you talked about normalization and accessibility. Pamela, that's exactly it. You're hitting the nail on the head, right, with the accessibility. Where, if not where I'm going, what partnerships, what exists already? Because we can't solve just the stigma part and then actually go create ways for everybody to get therapy all in one swoop, right? What I'm hearing is the normalization is where it's starting. If we can start with sort of this normalization, what novel approaches, Leslie, in your setting, understanding that setting, David, the product side, Srini, the solutions, what can we do to get to that normalization? Does it start with simply creating ways for people to be in that conversation at the very beginning? I think it's a strong one. What other ways can we talk? Because if we can start with normalizing this, we can start breaking down and moving down the line. Any thoughts on that before we sort of start?
So to give you a weird, crazy idea.
Love it.
When you go to the airport and you leave the bathroom, you have this smile and this frown that you just hit the button. It's like a survey. And I guess you're telling them whether you felt like the bathroom was clean enough or whatever.
Yeah, data capture.
And I've been talking to people in the past about mental health, like in schools, and that there should be like a baseline assessment for kids when they go to school, where you hit the face of how you feel, just to get a sense of the student body and where they are. And maybe if there was some simple way, maybe it's an app or something, where every patient is assessed as they move along their mental health state. And I don't know if it would be 10 phases or 3 phases or whatever, that just kind of get a sense of where they are, and then connect them to those partners and resources, or have conversations. Just a thought. But
no, I love simplicity. I think there's a lot of beauty in simplicity. And if you normalize it at a young age, we as adults start to look back and think, wow, it's so simple. Why aren't we seeing it in the same way? So, add to that, David.
Yeah, I like the idea of right at the beginning, as we were getting after Srini's and Scott's comment, like right after when you start, this is your landscape. This is your team. You've got a complete team, and mental health, social worker, nutritionist, like they're all part of your team. You're going to talk to all of them. You're going to do something with all of them through your next 2 months to 2 years. Like, you just start with normalizing that is the way it works. Your body, your whole everything, we're treating it. So, and then part of that stream of mental health are, so what's going on here? Because you don't know, right? So you hear stories of people you know, like people everybody knows, either great famous historical figures or celebrities or something. And then you hear stories of boring people like you, because you don't want to think like, oh, this only works when you're an amazing, Michael Jordan or whoever. It's actually 15 of my neighbors who are anonymous. Like, who would have thought? Who would have thought? In every sixth house, there's someone who has lived through this, and they've gotten this, and some of their anonymized stories. Because what you really want to find out is, like, it's more common than you think.
Mm-hmm.
They leverage it. Some people didn't leverage it, and they didn't have so much success. Some people did, and they did. Like, you start to see this is how it works. And then maybe the numbers come, because if you start with numbers, they're cold. Like, then it's like, oh my gosh, that's a lot. That's a huge percentage. So I think we got to build this story of getting people to believe that I can do this. This is for me. This is relevant. And then you start to educate them as, like, how do I even engage with mental health? And then where do I get it? And how long does it last? Like, and there are ups and downs, and so all those things I think we need to figure out how to weave in. But we got to start with, it's going to be there, and that's part of your care.
Yeah, David, what I'm hearing is something as simple as, we need to give thousands and thousands of people access to recording their story.
Yeah, and then curate. I think, as Leslie pointed out, social, like, the public is really good, but there's some icky stuff in there, and there's garbage, and then you curate that stuff.
Yeah.
Someone has to curate it, so that. But what would be cool is to look at the numbers and click and, like, that story and that story and that story and that story. Like, holy crap! Like,
yeah,
there you go, just like me.
To connect that a bit to what I want to go back to what Pamela said also, like, that's the kind of, like, maybe there is the upfront cancer story, and that's your introduction to your team. And like David's saying, like, this will involve all these people. Now, to Pamela's point, all these people don't necessarily sit in this hospital, right? So we don't necessarily have the therapist here and the nutritionist here or whatever, but this is the story, and we will help you, we'll direct you. So also, to Elizabeth's point, when you're in a fog and you have to start doing research into something you know nothing about and making your own appointments, like, it's not going to happen, or it's less likely. So kudos to you, Elizabeth, for doing that. But I love the idea of, like, the introductory story you get upon diagnosis includes all of this stuff. And if it is introduced to you that way, but in an actionable way. So I guess to Stacey's point, like, it's not just, hey, this is important, we're going to help you find it, right? And here are some avenues you can take, and here are stories that go along with that. And so it can certainly exist outside of the hospital setting, but the hospital setting is where we start, or the doctor's office, or wherever you are. I'm there for a diagnosis. I'm scared as hell. I know nothing about what's about to go on. I'm looking at my pragmatic checklist, like, how soon do I need surgery? Who do I have to get to help me? In that setting, that's when I need to be hearing this story and this idea of the emotional support and the mental support that I'll need. I feel like just even hearing that up front would make a big difference, perhaps, in my willingness, and then hopefully ability, if they can provide that, to get it.
Incredible and fantastic summary, but we have 2 minutes. Heather, thank you for that, because you've kind of pulled it all together. If I may, first off, thank you guys. Hopefully you're getting a bit out of this. This is just this is, in my mind, one or 2 seconds of the conversation, and we only had an hour. I'd like to quickly go through what we hear about normalizing and accessibility, normalizing this and getting through the accessibility, some key points that we'd like to build on. Normalization can start with storytelling, David, as we're talking about, bringing that through. How can we capture these stories and get them out there? And how do we get them out there? We really have this opportunity, this attention with cancer at the beginning of the care. At the beginning of that point, we've got their attention. And I think we all agreed that if we can put it out there at that right time, so it's like, okay, you're going to get 2 shots every week. Okay, you're going to get this, you're going to need this, this, and this. We have an opportunity with timing to create that normalization. Then there's going to have to be accessibility down the road, because normalizing it and claiming it's normal, but not having anybody that can deliver doesn't tell a good story. And again, the boat analogy, we need to get all these things firing on the same, all these pistons firing on the same cylinder. The money is going to be a big challenge, Leslie. I'm a big believer in what we do now and what you do. I think you are way ahead of your time. And this pandemic, and just pandemic is one part of it, but the pandemic and life itself, pushing along sort of the need and notion for this. I hope with everything that we can keep moving that work forward. But then just doing simple solutions also is what I'm hearing. Simple ways of creating baselines, of making it normal to talk about, register, weigh in on how you're doing, can really be a powerful, powerful thing, Sharon. I'm talking quickly, guys, because it's 10:29, and I'm glad we came up to the back end of the wall. But thank you guys all so much. What I also want to say, in SCED, we all have each other's contact information. I'm just Mark at flatwaterfoundation.org. We're all in there. If we need to connect, Livestrong has wanted us to push that we can also continue to do that. This is the very, very beginning of something, but we have talked about solutions. It's now 10:30. Am I missing anything? We're going to get cut off here quickly, but I want to see, am I missing anything in that summary? Because I want to be sure that we hear everything. Excellent, excellent.
It's perfect, Mark, and thanks for everything you do at Flatwater and bringing light to this.
Absolutely, Sri, and you and I are going to connect. Thank you for reaching out. I'd love to have conversations and start conversations between each and all of you about how we can get there, because this is going to come full circle, like I said, with our partners over at Livestrong, and how we can help make these potential solutions a reality. So thank you, guys. Would anybody else like, in closing, to add any to what we're saying? And again, thank you for letting me pull that off at 10:30. Hopefully you guys have enjoyed this. Again, my goal was to keep this moving forward, and I think we have some great takeaways. I've noted them and can be sure we can distribute this for all of y'all.